Good afternoon, everyone.
Good afternoon, everybody. Good afternoon, madam. I welcome all of you to this DNB clinical meeting series. And today, with great pleasure and with a lot of expectations, I'm so thrilled to welcome Dr. Lallu Joseph, who's a quality manager and also an associate GS of the CMC Vellore, one of the largest hospitals in the country to be accredited with NABH. She has been the pioneer in healthcare and also has been she has had a nice jump from healthcare and from being a mechanical engineer and also a trainer and being a VC of a software company to moving into completely different field of healthcare where she's again excelled herself. She is an executive general manager from Indian Institute of Management from Bangalore and is a passionate teacher, a leader, a trainer, especially in quality care as across the country with NABH, CAHO, AHPI. And she also been the principal assessor of NABH. And without much ado, I would like you to give the platform to Dr. Lallu Joseph to talk about quality and patient safety, a roadmap for anesthesiologists. Dr. Joseph, welcome. I welcome you all to our family of DNB Clinical Meeting Series. And I thank you for accepting this with a very busy schedule that you have. But we're really eager to hear from you because patient safety is a very integral part of an anesthesiologist because we are one people who are there from the beginning till the end of the surgery or end of any procedure that a patient undergoes. And we hold a lot of responsibilities. And I'm sure with your talk, you're going to impress our young minds who are there, who have joined us, especially our residents. You can, of course, impress them about quality and patient safety, which is really very primal requirement at this time. So I give you the platform to please go ahead and give us a kind of pearls of your wisdom. Thank you.
Thank you so much, Dr. Kalpana, and thanks for this opportunity given to me. I think I've been allotted about an hour and a half. Let me try and do justice to what this quality and patient safety is all about. I'm very excited to be in the midst of young minds because we have to start our training on quality and patient safety from the time they are into the portals of medical education. There's no point talking about it once somebody becomes a professor and then, telling them this is what needs to be done and this cannot be done. So I strongly believe that quality and patient safety education has to start from the portals of medical colleges. So without much delay in what I want to talk about, kindly give me the permission to share my slide and I will begin my session. Is it on full screen, madam?
No, ma'am. Yeah, now it's on full screen. Perfect.
Thank you so much. So my talk is going to be very, very broad-based, though I'm going to be touching upon anesthesiologists in particular, but I'm going to broadly talk about quality, patient safety, and the culture of quality and patient safety. What, as clinicians, one must have. It is a commitment to the patient that we are serving. So how do we start? Where do we start is a big question, because all of us know patient safety is a huge problem, not just in our country but across the globe. So let me begin with some data just to alert the listeners about the importance of patient safety, the kind of issues that we are facing on a day-to-day basis, how law treats us when it comes to some kind of a small incident or a major incident, and the commitment and the responsibility of the clinicians towards patient safety. So this is the structure of my presentation, and I'm just going to start with what is quality in healthcare. There are very different opinions about what is quality in healthcare. Many people across the country think that quality management is all about accreditation. People start working towards NABH, JCI, and when they get the accreditation stamp on top of their hospital and there's a gala event where the certification is presented, they think that is a quality. That is not quality. That is just the beginning of the quality journey of any organization. So the myth is that quality management is accreditation. And the other important thing that people think is accreditation should solve all our problems. No. In fact, it creates more problems. Lot of gaps come out and people don't try to sort them out, they just try to patch it up. So accreditation, though many administrators and hospitals think it should solve all the problems, I feel it's just the beginning of the problems coming out. What probably was hidden is just that it's coming out to the forefront. So when you ask the clinicians, this is the common statement we get. What is this accreditation? Documentation and documentation. How can documentation improve quality? Certainly, how can documentation improve quality? I'll tell you how it can improve quality. And the other important thing is it's for nurses and support staff and not for doctors. On the day of assessment, we see in many hospitals, the doctors start their rounds when the assessors get into the ward. So, they just don't want to be disturbed because they think it is only for the nurses and the support staff and not for the doctors. And this common thing is a phrase, is a show on the day of assessment. The hospital is whitewashed, every document is kept on place, and it's not the other days, it is only on that day of accreditation. Who are these fellows to tell us what to do and how to do? This particularly happened in my organization when we started with this exercise of accreditation and quality management. Let me tell you, we are a 125-year-old organization. And when we started telling them, these are the guidelines, these are the practices that we have to adopt, the common thing is that we have been functioning for 100 years. Who are these people to tell us what to do? Many think it is a waste of time, investing in quality, investing in accreditation. All these typically are waste of time. Why? Why do we think like this? There are several reasons. First thing is the lack of understanding of the principles of quality management. I told you accreditation is not all about quality management. Accreditation is only the starting point of quality. Quality management is far beyond accreditation. So I think you will have to take it out of your head that, if my hospital is NABH, my hospital is JCA, I've got quality, I've got patient safety. Certainly no. It is just the beginning of your quality journey. So therefore, our mindset has to now become, okay, I've achieved the basic minimum standard of accreditation. There are far too many things beyond this. It is all about that excellence that we need to strive towards. The other important reason as to why this is happening is implementing without understanding the right intent and spirit. Many quality managers tell, NABH wants this. I'll tell you a typical example. Like in our hospital, the pharmacists were told you cannot keep the vaccines on the door of the refrigerator. They thought it was an NABH requirement that it cannot be kept on the door of the refrigerator. But nobody told them why it cannot be kept on the door of the refrigerator. So on the days of internal assessment, on the days of accreditation, they'll all be kept inside. The other days it is kept on the door of the refrigerator. Why? Because they have a reason. It is all beautifully arranged on the door of the refrigerator. It doesn't fall. It is kept intact. But what is the scientific principle behind not keeping them on the door of the refrigerator? Every time you open and close the door, the temperature increases. So the cold chain is affected. The intent is that these vaccines will have to be stored between 2 to 8 degrees. Now, if the door of the refrigerator is kept open and if the temperature reaches 10 or 12 degrees, the efficacy of the drug is lost. So if somebody tells them this is the reason as to why you cannot keep them on the door of the refrigerator, then they will understand better. The moment the intent was told to them, this is the reason, this is why you cannot keep them on the door of the refrigerator, after that we have not seen these kind of issues at all. So implementing without understanding just because NABH says so or JCI says so is a major problem for the lack of understanding and people having diverse opinion about this accreditation and quality management exercise. I'll give you another quick example towards this. I'd gone for an assessment of a hospital in Hyderabad. Hyderabad taught me brilliant lessons. And this was a bypass surgery that was going on. The cardiothoracic surgeon was not sold to the idea of accreditation at all. So we as assessors, when we get in, we tend to talk to the surgeon, the anesthetist, everybody, just to find out what generally happens in a theatre environment. So I realized within no time that this surgeon was not sold to the idea of accreditation and he thought it was a farce exercise. But I noticed that for a bypass surgery, the right eye of the patient was marked. I was very intrigued as to why the right eye was marked. I'm not a medical person, but of course I've handled clinicians and nurses for several years now, almost 17, 18 years, and I know how to handle them. So I asked him politely, sir, is there any specific reason as to why this eye is marked? He said, I don't know, NABH wants it. I was really puzzled. What is this NABH wanting the eye of the patient who's going in for a bypass surgery to be marked and that to the right eye? Believe me, my friends, I went hunting for the reason. And then I realized the quality manager of this hospital had moved from an ophthalmology setup into this higher specialty hospital. And along with her, she carried the surgical safety checklist of the eye hospital and asking everybody to implement this. And this girl was just new in the industry. She had been trying to implement saying NABH wants this form, NABH wants this. No wonder the clinicians were very skeptical about this exercise. So the reasons are far too many. Without understanding the intent, people trying to push it down the throat of the clinical teams. Trying to copy and paste. In a hospital that I had gone in Dindugal, near Madurai, in Tamil Nadu, they were talking about coastal disaster. There is no coast at all anywhere close by. They had copied and pasted from a hospital in Kanyakumari where tsunami disaster plan was put down. And that copy-paste exercise has been brought into another town, another hospital in Dindugal, which had to really, so these kind of exercises happen all the time. And it's just copy-paste, and in Tamil, we say "E copy," which means, it's just copying even if there is a small b that is killed and kept, stuck to the paper. That's typically what is happening. Without knowing the intent, without understanding what needs to be done, people copy and paste the SOPs, protocols from one hospital to the other. Policing rather than facilitating. Now the quality management teams in most hospitals are used like police force. They become CID for the administration. They will have to go and find out what happens in this department, that department. Why are patients running away? So that is one of the biggest problems. And in my hospital, we are a facilitating force rather than a policing force. And that's the first thing that was told to us. So these are some of the reasons as to why the quality management and the accreditation principles are not understood very clearly. Now let me tell you, what is quality? Quality is doing the right things for the right patient at the right time in the right way to achieve the best possible results. This is by the Agency for Healthcare Research in Quality. This is the right definition for the right concept of quality. Doing the right things for the correct patient at the right time in the right way to achieve best possible results. This is, as a clinician, when you think about quality, this is what should be coming into your mind. But with the service excellence perspective in mind, there is another definition to quality, which is quality is meeting the stated and implied needs of your patients every time. Stated and implied needs of your patient every time. Let me give you a small example to demonstrate what is the stated need and what is implied need. Now, busy rounds in the morning and till 10 o'clock you have not had your breakfast and you decide to go out of your hospital to have a quick breakfast and come back. You're very hungry and you are a dosa fan. I'm from South India, from Tamil Nadu, so to us, dosa is the biggest thing. So, you decide to just jump out of the hospital, go to some Arya Bhavan, which is just opposite to your hospital, and have a dosa. When you get into the hotel, are you going to look at the menu card? Certainly no. You're going to tell the server, get me dosa. That is your stated need. Now, the server comes after 15 minutes, you're hungry, and the temperature is about 27 degree, AC is not working at all, and the place is smelling. And he comes with a plate of dosa, the sambar is cold, you waited for 3 colored chutney and there's only one red chutney there, no white or green chutney. He's bringing a glass of water with both his fingers into the glass, no tray or anything. And you are like raving mad. But still you decide, okay, I'm very hungry, I'm going to eat this dosa. He's not wearing any glove, mask, apron, nothing. He's just coming like that, scratching his hand and coming and serving this. You start tasting the dosa and the dosa is yummy. Are you going to be happy? But the dosa was your stated need. You never told him your temperature there has to be 22 degree. The place cannot smell. You have to smile. You have to come in 5 minutes. You have to get me piping hot sambar. You have to get me 3 colored chutney. You have to bring the glass of water in a tray. And you have to be wearing glove, apron, mask. Did you tell him? No. So your stated need was only the dosa. Though the dosa was good, you did not like the quality of the service there because your implied needs were not fulfilled. All those things that you expected him to do, he did not do, though you did not state it to him. That is what is service quality. Now, most often your patients who come to you are not going to tell you what they expect out of you. They're probably just going to come and tell you, make me better. You may be making them better, but if you're not communicating to them, if you're not talking to them, if you're not doing the right thing at the right time, if you're not, talking politely to them, there is no way that they can get the answers out of it. They will say, go to that hospital only in an emergency. They're probably good for an emergency, but not otherwise. So only when you meet the stated and implied needs of your patients, then there is quality. Otherwise, there is absolutely no quality in the minds of the people because to them, it is not the suture, it is not that needle that you use, it is not that infection prevention that you undertake because they don't understand technical quality. All they understand is, that aspect of communication, talking, making sure that they are felt wanted, making sure that they know what is happening to their dear one. That is what is most important. So quality has 2 dimensions, one from the dimension of the provider and the other from the dimension of the receiver. There are 4 absolutes to quality management. The first important principle is conforming to requirements. These are the requirements, these are the standard operating procedures, you follow them to the dot. That's the mantra of quality, conformance to requirements. Quality is always achieved by prevention and not by appraisal. How do you prevent an incident from happening? If you prevent all that, then you have quality. Not after it happens, going into the depth of it and understanding. So prevention is the second important thing. Quality has a performance standards of 0 defect. So you have to aim towards 0 defect, and that is the performance standard to say I have quality in my department. I deliver best quality to my patients. Quality is measured by the price of non-conformance. If there is an accident, if there is an incident, the price that you pay for that non-conformance is the cost of poor quality. One incident can take the name of the hospital. Imagine, a major incident happening, a fire in AMRI hospital in Kolkata. They were never able to come out of it. 91 lives lost. Have we learnt out of it, out of the non-conformance and the price the hospital paid for the non-conformance? Certainly no. Even today, most of our mock drills in hospitals happen at the car park. What is the role of an anesthesiologist in an event of an emergency in theatre? Is the anesthesiologist becoming the captain of the ship, or at that time you are fighting with the surgeon and trying to find out what is the role of the surgeon, what is the role of the anesthetist, and is the scrub nurse at that time trying to count the number of scrubs that they have used? So all that we need to do is to practice on site and making sure that we don't have to measure the price of poor quality and have non-conformance established in our setting. Healthcare and safety, we have huge problem. We talked about quality and safety go hand in hand. The odds of dying in a plane crash it's actually just 1 in about probably 2 crores or 29 crores. In a car accident is 1 in 5,000, but due to a medical error is 1 in 300 patients. I'm not saying this. This is the WHO estimate. And imagine this is from developed countries. It's an estimate by WHO that says that 1 in 10 patients in developed countries are harmed while receiving care. The AHRQ report is even more than that. IHI says that every year medical errors are the third leading cause of death in US after cancer and heart disease. Have we done enough? How hazardous is healthcare? We get very scared when we get into an aircraft, when there is a major turbulence. We think we are going to crash. But airlines is supposed to be under the most non-hazardous industry category or safe industry category. We come under the hazardous industry category, which means as a patient, it is safer for him to even get into a nuclear power plant or a chemical manufacturing plant rather than getting himself admitted in a hospital. They think they are very safe in a hospital, but it is equated to bungee jumping. As a patient, he is safer climbing on top of a cliff and tying himself and jumping from there, doing a bungee jump, rather than getting himself admitted in the hospital, as the odds of medical error or small incidents happening is comparatively more when you compare that with the bungee jumping. Failures in healthcare delivery, far too many. We keep hearing about this. Many times it's not reported. Improper hand hygiene. When our nurses look at the hand hygiene, though it is presented as 100% to the NABH assessors, all of us know where we stand. Not even 40-50% compliance. Non-adherence to PPE usage, medication administration errors, particularly so in anesthesia. Patient identification related errors, surgery on wrong patients, retained objects, fire, and very peculiar incident that happened some time back, nitrous connected to a patient instead of oxygen. And that patient went into vegetative state and finally died in one of the government hospitals in Tamil Nadu. So we keep hearing about these incidents happening on a day-to-day basis. Look at this. Fire at AMRA hospital, 92 patients dying. Power outage at Puducherry, killing about 3 patients. 22 patients in Soom Hospital, Odisha fire. Doctors operate on the wrong leg of a 24-year-old. Imagine what has happened. This is a trained, a chartered accountant. Do you know what happened to this particular case? This patient was to be operated on the right leg. He had a fracture. He was taken into theatre. The doctor had positioned him for the right leg. But within the theatre environment, they removed the cast and positioned him prone. So the right leg became left leg and the left leg became right leg. The surgical site marking was not done appropriately. This can happen to anybody. And this happens on a day-to-day basis, though it may not be coming like the way this incident came out. 15 patients hospitalized due to wrong drug given before sterilization. And this happened in your own city. 2 stuck in MRI machine for about 4 hours. What happened in this incident? The emergency push button was deactivated as the company felt it could be, the technicians may not know what to do. So they had deactivated the MRI emergency push button. So this technician was
Oh, you got
working in this
cameras
hospital.
outside, like. Yeah, so if you put the indicator on, yeah. This side camera will somebody.
So this technician worked in the hospital for over 32 years. The assistant to this technician was posted the previous day without any training into this setting. So the technician expected an emergency case to be brought in, and he wanted the assistant to keep a mask ready. Oxygen mask, this is what he told him. But the technician's assistant understood it differently and brought the cylinder inside. And both of them were sucked inside the MRI machine. Look at this. Have we learnt out of it? Every day almost we have issues happening. This beautiful lady, we all know about her. And the moment you look at her, you think about all the 27 plus plastic surgeries that she underwent. But little do we know that in 1996, her mother was operated in Sloan Kettering, one of the leading centers for neurosurgery in the globe, in Manhattan, and she was operated on the wrong side of the brain. Just because there were two Indian women posted for surgery on the same day. Can it happen to anybody here? Certainly yes. Every single day we hear of near misses happening. There was recently one case of one Kumar who was supposed to go for an angioplasty, who was rushed into the theatre, OT complex, for a cardiac procedure because there were two Kumars admitted in the ward. The other Kumar was to be sent into theatre and he was wheeled into the cath lab. Fortunately, both cases, the nurses, because there was a timeout that was conducted in both the areas, the patients were sent back. It can happen to anybody. So the role of the clinicians is far too much compared to what it was before, because Arnab Goswami is also watching. It is not just our own hospital administrators. We have to understand that the entire media is behind us, the entire public, and people know it's no longer the kind of clientele that we were dealing, that they didn't know anything about what was happening in the hospitals. Today they are well read, they know what to expect, they know what is going wrong, and they know very well when we don't disclose to them. So it becomes a huge responsibility on the part of the healthcare professionals. And that's why we keep seeing all these kind of incidents happening. They don't have trust with us. There is a problem. There is lack of trust with the healthcare professionals, and therefore mob violence is on the rise. We are to be blamed for this, because most of the times, if we are serious about what we are doing, if we take the pride in doing what should be done the right way, many of such incidents can be avoided. So this is the case I was talking about. 3 doctors, 2 nurses and 3 assistants suspended. Kanyakumari Medical College Hospital in 2011. The lady was admitted for DNC followed by a tubectomy, administered nitrous oxide instead of oxygen. After several years, the anesthetist got the relief that the cylinder was filled with nitrous instead of oxygen. The company that filled the gas was responsible. But in medical colleges, government setup particularly, anesthesiologists are the ones who are handling the medical gas system. So automatically the anesthesiologist was held responsible. But how will he logically be checking whether nitrous was filled inside that oxygen cylinder? And finally the doctor got relief on November 5th, 2018. Look at what he would have gone through for 7 years just fighting this case out. That's the problem. So it's not just limiting yourself to your OT environment. It is far too many things that you have to think about when you are practicing as a clinician. Now, all this is beautiful. We know what we need to do. But what is the culture in our country? Look at the safety culture. This is how our roads are. This is typically how we commute on a daily basis. And in Mumbai, probably in your metro train, you must be having 5 loads of people inside one metro train. It's a problem. There is no culture of safety in our organization. All of us are part and parcel of this system. So our technicians, our nurses, our clinicians, everybody goes through this and we are part of the problem. But when we enter into the hospital, we are expected to have the mantra of safety in front of us. We cannot have mistakes happening. So how is that culture shift going to happen? You are entering your hospital without a helmet. You are probably getting 3 other people in your bike. And then when you get inside, you have to wash your hands. You have to touch your patient. Before that, you have to use your, surgical, all your sterilium and everything. And then make sure that this is the right patient. make sure that you check that ID band twice, make sure you load the right injection, make sure that everything goes as per the safety protocols. So which is why developing that culture within the hospital environment is becoming a huge problem. So what is this culture? Unless all of us start thinking about safety, it is not going to happen. So the culture is, in simple definition, the way we do things around here. This is how we do something. That's the culture. When it is one person's attitude, it is opinion. Where Dr. Kalpana is talking about safety, 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 it is her opinion. Now, when that becomes everyone's attitude, then your department has the culture of safety. So when it is one's attitude, it's just an opinion. And when it's everybody's attitude, it becomes a culture. Which is why it's important to create that culture and not just leaving with one person's opinion and attitude. So please understand, culture is the way we do things around here. All of us start developing that, that passion for safety and culture, safety and quality. Then the department will have the culture, the organization will have the safety culture. And that's a very difficult thing to achieve, but that is where we should be striving towards. So culture of safety is the combination of everybody's attitude and behavior towards patient safety that is conveyed when you walk into the healthcare facility. When you know this hospital is committed to patient safety, you know the portals will be clean, the area is going to be clean. When you get onto the bedside, they will not touch a patient without using the sterilium. For every small procedure, the patient's hospital record or the chart is checked. Everything is properly documented, meticulously written down. The handing over happens properly. So then when you walk into the facility, you know there is the culture of safety that is established in that organization. So when you get into the airlines, you know they have the culture of safety, which is why they are under the high reliability organization. Ideally, healthcare should be getting into the high reliability organization, which means mistakes cannot happen. It has to be foolproofed properly. We may be laughing when the air hostess says, you put on your seat belt, you put your seats upright, you take, keep the window shades open, don't use your mobile phone when the airline is, when it's a takeoff or landing. We may not know why, but that's part of the protocol and there is an intent to everything that they say. So they don't want mistakes, and even if mistakes happen, they truly want to safeguard every individual passenger. So it's a highly reliable organization. Often high reliable organizations are complex, they are technology intensive, and as far as possible, they should be failure-free standards established. That is when we call as a HRO, high reliability organization. There are different levels of safety culture. Where are we in our country? We were probably pathological, which is no systems at all in place. Today I can't say that we don't have any system at all. Whatever said and done, the accreditation exercise has done wonders to the hospitals in our country, particularly the NABH. From what we were pathological, we moved probably 10 years back into a reactive culture where we had systems piecemeal here and there. We were not talking to each other. Then we moved probably into a calculative approach, a systematic approach per event. We started analyzing our incident, we started talking about it, we started taking the exercise seriously, we started reporting incidents. Now we are moving towards a proactive culture, which is comprehensive across the entire organization and not limiting ourselves to only our department. Till now it is little kingdoms of cardiology, anesthesiology, cardiothoracic surgery. Every kingdom is ruled by a king who's the head of the department. They don't want to talk to each other. Today it is more towards a multidisciplinary approach of proactive risk assessment, trying to understand what problems can happen, how do we make sure that things are streamlined. But what we should be aspiring is to move towards a generative culture, where safety culture is central to the mission of the organization. So we have a long way to go. These are typically the characteristics of a safe culture. It all starts with the leader. Leaders demonstrating the commitment to safety. A safety conscious work environment without any fear of or intimidation, harassment, discrimination. People should feel free to talk about safety concerns. and decisions that support or affect safety are very rigorously and thoroughly monitored. Trust and respect should permeate the organization. When you have all this, you have a good safe culture in your organization. Now, with all this, we are talking about the ideal thing of a beautiful, safe culture. What is the starting point? Starting point is accreditation. And particularly, now I am addressing an anesthesiologist group, audience pertaining to anesthesiologists. I think as a as a discipline of medicine, anesthesiologists are safety conscious. We have seen it on several occasions. Because to you, it is life or death. You have to be very, very cautious and careful about what you're doing. So that is part and parcel of what you're doing. Can you do better? Certainly better. So the basic thing to the starting point is the accreditation exercise. There are several requirements that are put forward by the National Accreditation Board in the chapter which we call as the COP. The 13th standard talks about the anesthesia services provided in a consistent and safe manner. This is the starting point. This is not everything to you. Once you have this established, you move towards the next level of excellence. Anesthesia services are provided in a consistent manner. What is consistent manner? In a very comprehensive, consistent manner, all of you have the standard treatment guidelines available based on sound clinical practices. Clinician 1 or anesthesiologist 1 cannot practice totally different from 2, 3 and 4, which is why you need to have your standard treatment guidelines available. When it is probably a cardiac case, what kind of anesthesia to give. This patient is more than 70 years. What are the various assessment parameters that need to be included as part of his care? So that's what is needed when you first talk about consistent care. The standard treatment guidelines, your own procedure manual with all the treatment guidelines documented. What should it have? What are the indications for the various procedure? The types of anesthesia that you provide for the procedure. Please understand, this is not applicable to local anesthesia. We are talking about the other types of anesthesia. The pre-anesthesia assessment is the second thing that we talk about. Results in the formulation of an anesthesia plan which is documented. In quality management principles, it's very clear, if something is not documented, it did not happen. You may say, I had sent a WhatsApp message to this person, my junior. No. If it is not documented in the chart, it did not happen. So it has to be documented. Who has to do the anesthesia assessment? Qualified anesthesiologists. Can trainees do? They are under supervision, under the care of an anesthesiologist. So based on the privileges provided by the organization, they are permitted, probably endorsed by the consultant. When should it be done? Before this accreditation exercise, we used to see the pre-anesthesia assessment happening just at the entrance of the OT when the patient comes in. That is an immediate pre-op assessment. That is not a pre-anesthesia assessment. Before the patient is taken into the OT complex. Before admission in case of elective surgeries, and this can be done up to 30 days in advance. So it is not necessary, it's just 24 hours before, 48 hours. But the pre-anesthesia assessment has to be completed separately and documented. So what are the various components of your anesthesia plan? Should be formulated when you do your pre-anesthesia checkup. It should include your pre-medication, type of anesthesia, the special requirements if there are any, and anticipated post-anesthesia care. The most important thing to remember is to use a standardized format, templates. I'm sure your hospitals must be having certain standard templates for pre-anesthesia care, not just a piece of paper. When you give a piece of paper, what happens? The plan is not structured. You may miss out, you may forget to document certain things or do the assessment itself. That is why templates help. It structures your process, your way of thinking, which is why accreditation bodies often talk about templates. Template is also a problem. I'll tell you about these checklists. We tend to keep these checklists so that people follow that. The biggest
See Thomas or
You remember that?
कुठे बोलला बोल.
सरळ आहे तो पण नाही झाला आम्ही आपण उघडा असेल.
Yeah. So the kind of checklist that we use in many occasions become like tick list. Just to break the flow, let me tell you this example. The story that happened. Again, I had gone to Hyderabad for the assessment, and most often when we go for assessment into the OR, we'll ask them, "Do you use the surgical safety checklist?" And during assessment, the nurses are all tensed up and stressed out. So I was in the holding bay asking the nurses, "Do you use the surgical safety checklist?" The patient Loganathan was just getting wheeled into theatre. I don't forget the name also because this, just shook me the way it happened. And the nurse from inside the OT came running through the corridor and handed over the surgical safety checklist of Loganathan. Loganathan was in the pre-op area. This checklist for Loganathan, the pre-op was filled, the timeout was filled, and the sign-out was also filled. She is right. She is using the surgical safety checklist. But is it with the right intent? This poor Loganathan was just in the holding bay. Everything got ticked just as he entered. So the intent is not understood. Checklists that we put often become like tick lists. We know the narcotic prescriptions even before the patient is wheeled in is all filled and kept ready. That's the problem. So we have to make sure with this culture of safety coming in, all these are taken very, very seriously. Now coming to the third requirement, pre-induction assessment. This is what you do at the holding bay. A pre-induction, immediate pre-operative assessment is performed and documented. That again has to be documented. Who's in charge? The anesthesiologist. What should be documented? Of course, if other parameters are okay, if there is any change in anesthesia plan, you may have planned for a spinal anesthesia. But at that point in time, you realize that this patient is anxious, scared of spinal, that you want to actually convert it into a general. Do you do that? Yes. How do you do that? You conduct the assessment again and you probably document saying that there is a change in anesthesia plan as a result of the patient situation. So when anesthesia should be provided urgently, both pre-anesthesia and the pre-induction assessment can be performed simultaneously, which means it is done at the holding bay itself for an emergency case. The fourth important parameter that accreditation NABH talks about is informed consent. Hundreds of questions come. Informed consent for surgery. Has the anesthesia consent also clubbed? Is it okay? Certainly not okay. Anesthesia consent has to be separate from a surgical consent because the risks are totally different. These are two different procedures. So therefore, in the pre-anesthesia checkup, you will need to take the consent for anesthesia from the patient for your anesthesia, depending upon the ASA risk grading. If the patient is at high risk, certainly I'm sure you must be taking a high risk consent. You will have to clearly explain the risk benefit alternatives, explain clearly to the patient and take it in the consent form. And I'm again telling you it has to be different from the surgical consent form and not clubbed together. During the patient induction, during the case, what are the various things that you need to monitor? You may be monitoring. They may be connected to the monitor. All ETCO2, all parameters are properly monitored. Is it also documented? You have to document that. If your monitor can get you the printout completely, you take that and stick to the record. But you need to make sure that the recording is available. What are the various things? The heart rate, cardiac rhythm, respiratory rate, BP, oxygen saturation, ETCO2, temperature. You may have the frequency every 2 hours, every 15 minutes, every 30 minutes, depending on the protocol that you have put down. So you will need to document all these in the case sheet of the patient. Again, the patient's post-anesthesia status is monitored and documented. Again, who's responsible? The anesthesiologist at the recovery bay. Here again, you will define that these are the parameters that you are going to be monitoring and documenting. So beyond that, if it's an unstable patient, you're shifting the patient to ICU, who has to monitor? The intensivist there will have to monitor and make sure that it is properly documented. The handing over chart will have to be clearly mentioning all the parameters during the handing over. The anesthesiologist applies defined criteria to transfer the patient from the recovery bay. Your recovery nurses may be monitoring this. They may be filling in the record. But Just before the patient has to be shifted out, the anesthesiologist will have to ascertain if you are using the Aldrich scale or any other scoring pattern to say that this patient is fit for transfer from the recovery bay to the ward, or if he is still not okay, to the ICU, depending on the condition of the patient. So you are free to decide on the criteria that you use for shifting from recovery to the ward or ICU. The type of anesthesia, anesthetic medication are documented in the patient record. Everything. It's so crucial to document. Who was the anesthetist? Who was assisting him? When did the induction take place? What kind of anesthetic agent did he use? Did he have any complications? Did he have any blood loss? When was the antibiotic given? Everything, we call it SNDT with the signature, name, date and time. It's so important, not just for medico-legal cases and high-risk cases, for every single case, because you do not know when what is going to happen. So documentation is crucial, because that's the only thing that's going to save you in case there is a problem. Then procedures shall comply with infection control guidelines to prevent cross-infection, management of all your circuits, other infection control measures including the cleaning, shifting, transferring your hand hygiene, scrubs, all that will have to be adhered to based on the policies put down by your infection control teams. Intraoperative adverse anesthesia events are recorded and monitored. How do you record them? You may have a system of recording in a register, or recording into your system, your HIS, or phoning up and telling the HOD there is a problem and somebody else is noting that down. Whatever is your system, you record through your portal, your sentinel event reporting, incident reporting, whatever is the system. The most important thing is to capture every small incident also. It could just be a near miss. Capture it, document, and then follow up on that to take corrective preventive measures. I'll talk a little bit about how to analyze incidents, because it's so crucial. Without knowing that, it is just, people go by hearsay. The gossip mongering will happen. And then, the senior leaders will have their own coterie of people around them, just trying to listen to them and trying to take corrective preventive actions. That doesn't help at all. There is a scientific way of getting into the problem, the root cause analysis, and I'll touch a little bit in the next 5 minutes. So, when you talk about anesthesiologists and quality, patient safety, lots of compliance related basic minimum things to adhere to. So far, the 13 points that I talked about with regards to the NABH or any accreditation requirement is the basic minimum requirement. If you follow that, you are safe. If you have standard treatment guidelines, all of you will adhere to that. If you conduct clinical audits, it's good for you to understand whether you are doing the right thing. So that's the whole idea of doing it. In our organization, every undergraduate intern, it's mandatory for them to do one clinical audit. And they have to get it done through us. We post them in anesthesiology, we post them in obstetrics, medicine, everywhere. And they have to do that and report, submit, talk to the department and then submit. It has made a huge difference because it's the culture of openness that has come in. And we bring out a quality journal every year with all the 150 clinical audits done by the interns. Let me tell you, you start looking into the data, that is when you know the quantum of problems which you otherwise will not notice at all. So, for your involvement in patient safety, the most important thing is to create the culture of safety, for which you first thing is to standardize your protocol and audit the compliance to your protocol. So, when we talk about that, the standard protocols, you need to really audit them on a regular basis to see where you stand. If you do not audit, you will never be able to make sure that the compliance is reaching. So small incremental changes are okay. If previous audit shows 70% and now you have reached 75%, be happy, celebrate. Next month it will become 77, then it will become 80. So you need to celebrate, you need to be happy, and compliances do not come overnight. If it comes overnight, it's a failure. It's because there is somebody who's sitting there on the top and hitting. It's not the culture that's coming in. Culture comes very, very slowly, but you have to be patient and you have to persevere to make sure that the culture is sustainable in the organization. So look at this, what started in our hospital in 2009 as a simple surgical safety checklist. We have iterated it more than 7 times based on all the problems that have happened. What used to be like a joke in 2009, like the way I talked about the nurse filling in the pre-op, intra-op and post-op, today is done so religiously. There cannot be a case conducted without the timeout being called. Nurse will not permit, the OR nurse will not permit. So what used to be just a sketchy surgical safety checklist has become a 6-phase surgical safety checklist today and fully complied upon. The second important thing is to encourage incident reporting. The more the incidents come, you must be happy. We call this as the Heinrich's triangle. When 300 near misses are there, you probably will be having about 29 minor incidents and 1 serious. It is that 1:300. Alright, so you really have to look out for near misses. If you don't plug those near misses, you will have problem. So allow, encourage, give chocolates, give treat to people who are actually reporting near misses, even if it is very minor. And the current culture in our system is that we only report when there is a harm to the patient. When there is no harm, we generally don't disclose. And near miss also, okay, just forget about it, everything is going on well. But what needs to be done is that all 3 aspects, patient harm, no harm, near miss, report them. Get into the details of no harm and near miss. If you don't do that, you will end up with a major problem eventually. It's like the Swiss cheese. So make sure that you get into no harm and near miss in reporting. Incident reporting should be very simple. Don't expect everybody to fill a 100-page form and submit. 10-15 things to mandatorily fill. Just basic things, name, time, where did it happen, who was involved, what category was it, just a small description and immediate action what was taken. That's good enough for an incident reporting. Others can then dwell upon it in detail and find out. If you keep a very elaborate form, nobody is going to fill it. They will say tomorrow I'll do it, day after tomorrow I'll do it. So keep it very simple. Incidents are often underreported for these reasons. There are several studies as to why people are not reporting. The most important thing is blaming people. Concerns over the fear of reporting, blaming, incompetence, too long and too time consuming, perceiving errors that are not important, thinking that this is not an important error. No need to report if patient is not harmed. These are the major problems as to why incidents are not getting reported. So, in order to improve incident reporting, encourage anonymous reporting. Make sure that people know the benefits of reporting. Make them feel safe. Don't reprimand. Don't punish them. So, have a very good relationship with the staff. You don't have to have spies, but you just have to have a very good open relationship with the staff, not just the doctors, the nurses, the technologists, and a very working, good professional relationship with the physicians. Automatically the culture of reporting will come and the reporting, this culture of safety will also come in. Now, the way you do it is the way how you beautifully get into incident reporting. Don't make it look like a courtroom scene where all your staff are there and questioned and who did this, who did that. Doesn't help at all. We have to understand that mistakes have happened. It is bound to happen. How do you typically analyze these incidents? Perfection of systems do not happen overnight. That's why quality management is there. It is all about achieving continuous improvement. And the essence of this continual improvement is effective problem solving, not just trying to wash them under the carpet. Make sure you get in depth and do it in a very scientific manner. So I just want to put this 3 definition in front of you. Kappa, kappa, kappa. Everybody talks about kappa without understanding what is this kappa. Kappa is a beautiful term. Correction, corrective action, preventive action. What is correction? The action to eliminate the non-conformity. Immediately, a false ceiling falls down. What do? Immediately fix it. A child, you have a child and the child is running, has a fall. What do? You immediately put a band-aid. Child is crying, you put a band-aid. That is correction. Corrective action is the action to eliminate the cause of the non-conformity. Now you are getting into why did the child fall? You realize that there is a small, a small area with a, the tile has gone off. So child had a fall in that place. So you realize it is because of the tile in that floor that had just slipped off, the child had a fall. So you are trying to fix that tile, which is corrective action. Action to eliminate the cause of the detected non-conformity. Now preventive action. Nothing has happened in your bathroom, but you are thinking my dad may walk in there. There is one more tile which is slightly giving way inside the washroom. Let me go and correct it now before something happens. That is preventive action. Action to eliminate the cause of a potential non-conformity. So with every incident, let's say there is a wrong medication that is administered to a patient. You realized it is because of a look-alike drug, probably in the same tray. Now, this is just at the induction room. Now you are thinking, okay, in my cath lab or in my MRI room also, I noticed all these things. Nothing has happened there. It's kept in two different areas, but potentially it may happen. The nurses there may not know. Go and correct it there also. Whatever action you're taking here, you make sure that it is corrected everywhere. So these are the definitions of correction, corrective action, preventive action. So correction is like a first aid, instant action taken to correct the problem, or action to reduce the impact of the problem. Bleeding is still not controlled, child still has bleeding, but with the band-aid it is reduced. So you have acted to reduce the impact of the problem. Corrective action is reactive. You are getting into the root cause. It may be multiple causes. You are trying to address them. So that is problem solving. You are taking steps to eliminate the cause of a non-conformity, the undesirable situation, in order to prevent a recurrence. It has happened. You don't want a recurrence to happen there. Preventive action. It has not happened. You are taking a proactive approach. The undesirable situation has not happened. You are anticipating that it could happen. There you are preventing an occurrence. It has not happened so far, but you are preventing an occurrence. So as quality people, as safety, what we need to do is to look into prevention all the time. You know, one small incident has happened in one area. Across the organization, how do I make sure that the systems are made foolproof so that I prevent them from happening in the other areas? So just a quick example of what is corrective action. Food served cold to the patient, replace with hard food. You realize there is a problem there. You replace it immediately just so that the patient doesn't start shouting. What is it? You're only doing a correction there. You don't know why it happened, but you're just keeping him, maybe okay. Metal detector at the entrance of the MRI room. You know there are potential problems. So you're preventing something from happening. Alcohol-based hand rub kept at the bedsides because the hand hygiene compliance of doctors and nurses was found to be very poor. You know the root cause because it's not available in front of them. So you're taking a corrective action here. So these are beautiful terms, but it has to be used correctly. I'm not getting into the details of all these examples, but let me just take you through one small example here. This is a real incident that took place. 4-month-old baby for cardiac surgery at 7:30 a.m. was given bath by night duty nurse at 5:30 a.m. with hot water as part of a pre-op preparation. Nurse checked the temperature of the hot water with her gloved hands by pouring water on top of her gloved wrist. Baby sustained burns. What is the correction here? Treatment provided immediately to the baby. Corrective action. Temperature checking of the hot water for bath to be done with a thermometer. Now you realized, okay, it has to be with the thermometer. You have a bath thermometer which is provided. Now this could potentially happen in a wax bath, in a foot therapy for diabetic wound patients, or even a sitz bath that we commonly advise after pile surgery. So you want to make sure that the temperature there is alright and you are providing them with the bath thermometer. So any small problem happening in one area can be looked at a system perspective in multiple areas and corrected. That's the idea. So prevention is what needs to be emphasized. With all the mistakes you are identifying, get into prevention. So the way to problem solving is not the traditional approach which we are used to. We have to go into a structured problem solving mode, not just go by gossips. The traditional approach, which all of us are part of, is to jump to conclusions. We are used to working with that person, that nurse for 20 years. If she comes and says, she's always correct. She will always tell you the right thing. So you will listen to her, or some technician who's worked with you for 5 years, 6 years, jumping to conclusions. We are only treating the symptoms. We are not evidence-based or data-driven. We are only short-term focus. Okay, my manager is going to ask me, my CEOs are going to ask me, I have to have my report ready. Let me call 2 people, fill up the form, just do an inquiry, and after that it's done and dusted. No follow-up. This is the traditional approach. In structured scientific approach, you go into identifying the root cause or all associated causes. You collect as much data as possible. The idea is to have a long-term focus so that problems don't happen. You will continue to follow up with your recommendations and implementation. So, what do? You form the team. Together, everyone achieves more. When you form a team, don't limit yourselves to only the anesthesiologists. Have your techs involved, have your nurses involved, have other surgeons involved. A multidisciplinary group, small team with thorough knowledge about the system. Clear purpose and role. Team will start fighting in the beginning, but when the purpose and roles are defined, the mutual accountability comes in and they will all start working towards complementing each other and finding the right solutions. So this is the scientific way of problem solving. We call it the PDCA approach for problem solving. The first step is very important. Planning, defining, analyzing the problem, generating solutions, selecting. So the first step, 1, 2, 3, 4 is the plan phase. Then you get into implementing phase. Then you evaluate whether your implementation is okay. And then you standardize your protocol. I'll quickly take you through the steps. First thing is defining the problem. If you have ever caught in any police case, you know about the FIR. The police will ask you, when did this happen, what time, who was there, who are the other people, what phone call did you make, whom did you speak to. So putting that like a FIR, it's like a storyline, is the most difficult thing. If you have already done it, if you have put the problem, if you have defined the problem is half solved. So narrating the problem, putting that in the form of a storyline is what you need to do, for which you may want to even walk into the area. Japanese call it the gemba. Walk into the area, look for potential causes, observe, take inputs from people who have been there, carefully put down everything together. And that is the first step and the most important step. Then you get into analyzing the problem. You have to get into the root, not just the symptom. It's not just the weed, the top of the, the plant. But the causes are all driven, hidden deep inside. It need not be just one root, it could be multiple roots. So you may want to get in depth, for which you use certain tools. And the straightforward tool we call as the 5-way analysis. If you have a 5-year-old, if you have a 2-year-old, they'll ask 100 questions. Why is the sky blue? Why is it raining like this? Why is there a puddle? Why are you always shouting at me? Why? That's the 5-year-old approach. It is developed by the Toyotas in 1970, and they are the pioneers in quality management. So look at this as an example. Question number 1. Why did the patient arrive late to OT? Patient had to wait for the trolley. Why did the patient wait for the trolley? The replacement trolley had to be brought from another ward. Why did the patient first of all need a replacement trolley? The screws of the side rail came off. Why did the screws come off? They had not been checked periodically. Why were they not checked periodically? There is no preventive maintenance at all. So the patient coming late to OT, otherwise you would have scolded the ward nurse. Now look at the root cause of the problem here. There is no preventive maintenance for your wheelchairs and stretchers. So instead of shouting at that person, you need to understand why this is happening, which is what we call as the 5-why analysis. So it's a very, very straightforward one. Then you get into tools which I am not getting into details. Then you now know what the problems are. You do a brainstorming to have multiple solutions to this problem. This problem straightforward. Get the engineers to do the preventive maintenance, talk to your CEO, get them done. Make sure it's all followed up. But when there are potential problems that your multiple causes are there, you brainstorm the solutions. You have multiple solutions. Do you want to implement everything? That's another problem with all of us in India. We want to sort out everything. Not possible. What is it that we want to prioritize? There is a prioritization matrix. Easy to implement, the impact. If it's something easy to implement and the impact is very large, do it now. That is what is there in this quadrant. If it is easy to implement but the change is only small, you do it later. Why waste your time immediately? It is very difficult to implement, but the impact is very large. You plan for it now. It's difficult to implement and the implementation impact is very low. Don't bother about it at all. Don't do it at all. So the vital, essential, desirable is very important. We always try to pluck that apple which is low hanging. That's not enough. So understand the solutions, prioritize and get into those that will really give you the impact. Now you are getting into implementing the solution. Not the HOD sending a letter, a circular and the CEO endorsing that. Not going to help. Involve all your stakeholders. Appropriately communicate. Draw out the implementation plan. Identify somebody who's as a leader, as a champion to implement this SOP. And the RCA team, your small team that was involved in understanding the problem should also be involved in the exercise. So, once you do that, then evaluate whether your solution has brought the desired change. Don't just send a circular everywhere from tomorrow, this is the protocol. Implement in one small area, 1 or 2 theatres. Understand whether the solution is first of all okay. See if it is creating the right impact. And then you standardize the protocol. Without doing a piloting, do not go by assumptions. Do not go by what your team also thinks is okay. Just do a small pilot, understand, and then you put down a standard operating protocol. If you don't do that, whatever we are trying to close as root cause analysis, CAPA, corrective preventive action is just overnight exercises. And for all this, you have to provide the leadership. Leadership is not just sitting there and understanding and shouting at people and giving memos to everybody. When incidents happen, that person who committed the incident is equally upset. He is scared. He is the second victim. The person who suffered, the victim, your patient, is the first victim. The person who committed that, you think he is happy? He did it just like that. He is also going through stress. He needs counseling. He needs that support and the help. So treat that person like the second victim. There could be slips and mistakes happening, and that is where leadership comes in to console, coach, discipline. Providing that mentorship is so crucial, which is what we call as the just culture of console, coach, discipline. And if it is reckless behavior, throw them out. Multiple times problems are happening, there is no discipline, they are not bothered. You will understand. At that time, don't have mercy. And once or twice you're noticing at-risk behavior, coach them, mentor them. And when you know it is a human error, that person was not to be really, everybody does mistakes. When it's a slip, when it's a lap, when it's a mistake, console and be a leader to support that person, support the team, which is what is important from the leadership side. And this is my last request and plea. We have huge number of patients. Without the help of patients, patient safety cannot be achieved. Patients are jobless lying there. If you are able to interact with them, understand whether the protocols are implemented, whether the postgraduates actually went and did the surgical site marking, whether they took the consent, whether they actively engaged with them, they will tell you. I had an eye surgery a couple of years back. The only thing I was looking out for was the surgical site marking on top of my right eye. I was an engaged patient. I would have never allowed my surgeon to block my left eye. Because as a patient, I'm an empowered patient. I know what can go wrong. I was only watching if the healthcare workers were washing their hands. So there is a lot that an engaged patient can do. So how do you engage with your patients? There are several ways. One is your patient advisory council. You can have patients who have gone through your system as part of your advisory council to tell you there could be better ways of doing. Every month you can have a meeting. Once in 2 months you have a meeting with them. They will tell you, I had difficulty coming to your department. Your staff can do this. They were explaining everything in English. I did not understand. You may want to have an interpreter. So they will give you best solutions. Patient reported experience measure is another important tool where you think your protocols are implemented, whether your postgraduates and your junior consultants are actually explaining to them. Once in a while you do a survey with your patient to understand whether the pre-op procedures were carefully carried out by them. So one structured validated questionnaire that we have developed for PREMS, I'll show you. Engaging patients. This is a validated tool, and CAHO did it for 17 safety measures. Did any of our team members verify your hospital registration number? Did the team ensure that you had adequate privacy during your consultation? Did the anesthesiologist clean his or her hand before examining care? So this is a validated one that we have prepared. If you are able to use this and get more validated questionnaires based on your situation, and if you administer this once in a while with your patients, they are also engaged. They are going to give you that most valuable feedback that if you don't follow may end up in a problem at some point in time. So with regards to PREMS, and the other one is the PROMS. PROMS is outcome measures. We all know about spinal anesthesia and the outcome. People have a perception that it can lead to some backache. Or what was the outcome exactly? Did they really have backache? What gauge needle did you use? Who administered the anesthesia, gave the spinal, or let's say 1 prick, 2 pricks, multiple pricks, whether that. So you really want to see the practices and the outcomes your patients have derived as a result of that. That again you can ask your patients post-surgery, maybe 1 day after that, the same questionnaire after 7 days, the same questionnaire after 3 months over a phone, and find out whether the outcomes are better. That will help you fine-tune your outcomes. So patient-reported experience measures are self-reporting instruments that measures the patient's perception or experience while receiving the care. And the PROMs are after the care. You are following up with them to understand the outcomes of the procedures or the intervention that you have done. So these are good ways to engage with your patients, not just for safety, but also to measure the outcomes and the quality of the care that you have delivered. We leave with just some patient satisfaction surveys. These are important scientific surveys that can be done to understand whether your services are reaching the patients and the outcomes are better. So that's the end of my talk as to how you can create the culture of safety, quality in your organization, the role of leadership, how do you analyze incidents, how do you console, how do you manage the workforce, how do you treat people as partners in care delivery, how do you engage with patients again as equal partners in healthcare delivery. All this is only possible if you have love. And I really like this quote by Avadis Donabidian, who says, system awareness and system designs are important for health professionals, but they are not enough. They are only enabling mechanisms. It is the ethical dimension of individuals that is essential to a system's success. Ultimately, the secret of quality is love. You have to love your patient, you have to love your profession, you have to love your God. If you have love, you can then work backwards to monitor and improve the system. And that's exactly where we are as committed professionals. You've all come into this profession with a lot of love for your patients, for your God, for yourself, for the profession that you have taken. And it is that commitment that is actually taking you towards excellence. And I really appreciate you for taking your time and joining this session, and Madam Kalpana for giving me this wonderful opportunity. Thank you so much.
Thank you, Dr. Joseph. The pleasure was always ours. We had learned so much from you today. And before I delve into some more questions, which I hope some of our people have them, I'd like to ask you a question, if I may. I work in a cath lab setup very often, and most of my patients are daycare patients because they come in for a angio SOS plasty in the morning. So if the surgery is, say, if the angioplasty is booked at 8 o'clock, they kind of walk in at 7. And we are lucky if they've already got their serological markers done. And either they are shaved or they're going to get shaved, and then an IV line is started and then wheeled down. We actually even though we have a DNB resident team, sometimes even the team does not have time to, reach them and do a PAC on them. So we generally end up doing a PAC just at the doorstep of the cath lab. And so I'm sure that, as you rightly said, would be occurring in many NORA situations as well. I mean, incidentally, there was an incident in our hospital on the same thing. And the anesthesiologists were asked that why was this patient not seen? And, we were at our wit's end to explain them that when a patient walks in at 7:15 to the hospital for 8 o'clock where he's being shaved, is that it's really difficult because the surgeons are waiting down. The sister in charge is, she's time bound that, then, that way. So it's not possible to see a patient. We had to see the patient just outside the cath lab. Now, in such a situation, can you tell me in what way can we do amendments that we can improve our anesthesia preoperative quality care?
Yeah, I think it's a common occurrence everywhere, madam. It is not new at all, and it is to any NORA situation. Non-operating room anesthesia is all about that. The first thing is to have a standard protocol established for your cardiologists who are posting these cases, to say that these are the basic workup that needs to be done. And there is, and most often you are not going to probably it's a monitored anesthesia that you are going to be giving. And if it is something that requires general anesthesia, you probably will be seeing them. I don't think you will probably not see them, right? For a GA, I'm sure you will be seeing them. So what is required in this situation is for the cardiologist to be working up on this patient based on the protocols that you've already given them. And certainly just before induction, which is at the receiving bay, it is your responsibility to make sure that you see the patient. I'm sure you're doing that. Immediate pre-op.
Yes, we are.
And you're documenting.
Yes.
That is good enough. That's absolutely fine.
Okay. Dr. Alka Halbe, who's our chief coordinator, she's joined us as well. Ma'am, would you have any questions to ask or any comments to be made? Next, we also have we have Dr. Madam Nayak and Dr. Dhaigude with us, senior anesthesiologist. If there are any questions to be asked, please unmute yourself because I don't see any questions in the chat box as yet.
Dr. Joseph, you spoke very well, and I think you gave us the in-depth, absolute description of how the quality and safety can be maintained.
Thank you.
Congratulations to you. But I'm a pediatric anesthetist, and we often do minor cases as a daycare basis. And as Kalpana said, they always walk in late, and then admission process, and then going to the room, and then coming to the theater. The whole procedure takes almost an hour. And our case is posted at 8 o'clock, and the patient walks in at 7:15. So I think even if, the consultant surgeon who tells them to walk to reach the hospital early, but they are staying nearby, they just come leisurely, and they say child hasn't woken up, this, that, they give all kinds of
Yeah.
In that case, we have to see the patient just before getting onto the table.
Absolutely, ma'am. And this is again, it's a common phenomenon. And the idea is that you educate the patients. So you may want to actually prepare some kind of educational material and flyer and hand over to the clinician to say the importance of fasting in such situation, and what if they don't fast, and the importance of coming on time, so that the clinical workup is done and for their own safety. So if you are able to actually give that and try it out, I'm sure the clientele also varies from hospital to hospital. I don't know the Mumbai clientele that well, but certainly our group of people, if we tell them 8 o'clock, they come at 7 o'clock.
Hello.
It's all about.
I'm unable to.
Now, our clientele is very fussy, and in fact,
I fully understand. Yeah, so it is important to at least educate them. You can even use the technology tool. If you have their mobile numbers and all that, send some messages to them ahead of time to say the importance of fasting. It could be pre-formatted messages to them saying why adequate fasting is needed, why coming on time, and who will see them, what kind of a workup will they need prior to the procedure, because they are going in for some kind of anesthesia. If you give them a slight fear through these messages, I'm sure they will be there on time, ma'am.
Yeah, thank you. Actually, I had seen those flyers or the pamphlets which are given to every patient coming to the hospital and going for surgery. So it's a kind of a common flyer which gives all the information about the fasting and what are the disadvantages and when you should reach the hospital, why certain blood tests are done and all those things. I think we should have those printed, just one simple page.
Short.
Something.
Yeah.
I think, Kalpana, we should try and do that for our patients.
Sure, madam. Alka, madam, we can,
Yeah.
we can hear you.
Can you hear me?
Yes, madam, we can hear you.
Yeah. This was a wonderful talk. It was like a song, right from the beginning, and the wonderful. I really loved listening, to you.
Thank you, ma'am. Thank
Yeah.
you.
And see, I work with urologists, and these are all elderly patients, and sometimes they are hard of hearing. Sometimes they cannot see, So that's a very difficult to sort of, communicate with them or sort of understand them, what are they saying. So that's a difficulty we face many times. And the incident took place about, I think, 3.5 months ago. That was a patient, similar looking elderly patient, They were wheeled, and it was not my patient. It was somebody, and ortho that day, unfortunately, ortho and we were working together. That patient looked the same, and the patients were exchanged. Okay. Luckily, I had seen the patient on the previous day,
Yeah.
So I could identify this is not my patient. And I ran out and I told them, I said nothing to do. I ran out and I went to next theater and told them, please do not start anything. This is not your patient. And the files were still outside. The files were with sister. So this is what happened in spite of we have that all WHO, everything's this. This is just because elderly patient, they cannot speak or they cannot hear. That's the thing,
Correct,
I
ma'am.
don't know whether we should allow the attendant to be with the patient till inside,
Yeah, so that is another thing with the vulnerable patients. Typically, I mean, see, there are multiple factors here. Number one, of course, is not just look-alike and sound-alike medicines. It is look-alike and sound-alike patients too. So we really have to be careful with the names, particularly in the ward and all that. When similar sounding named patients are admitted, alerts coming into our system in the clinical workstation itself, or to segregate them. So if they are coming from different areas, it's a different problem. But if they are coming from the same ward, these things happen. And the second important thing is the ID band. So the ID band within theatre environment is also critical. Though, you may be starting lines, in that case, at least onto the leg, the ID band should be there. Because if you are not having the ID band, do you have them with the ID band inside the ward?
We do have ID band, but the one patient, what happened, same hand they wanted to take IV and the ID band was removed.
That's the problem.
Band was removed because it was coming in the way.
Yeah.
That is what happened,
Yeah, so I correctly guessed then. Because this ID band then at least has to be tied on to the foot. So without that, in our setting, we do not permit. If they cut for want of starting IV lines, it has to be put on the patient, because these kind of things can happen. So you cannot have any kind of slip happening anywhere. Imagine if this had swapped.
Yes.
It's, so we really will have to fine line and fine tune the systems, assuming that all these can potentially happen. People used to laugh at us, whether we are in a state of paranoia all the time. But actually, you have to be with the state of paranoia.
No, you must include this cutting of an ID band to take IV and this elderly patient not speaking, because you have a lot of collection of this. I just thought that's why I should speak to you this.
It's a very, very valid point, ma'am.
Yeah.
And it can happen anytime. Yeah.
Hello?
Madam, yes, madam, please.
Yeah.
Dr. Naik, yes.
I'm Dr. Naik.
Hi, ma'am.
I must say that was a very engrossing and very informative talk, Dr. Joseph.
Thank you.
I'm
Thank you.
very glad to know that I have the opportunity to listen to your speech. Very, very, and also I'm very impressed with very impressive career graph you have. As an anesthesiologist of nearly 49 years of experience, I give very importance to, and I always tell my students, there is no shortcut to safety. There is absolutely no shortcut. You cannot say my patient came at this time and this happened this time. You have to teach. I mean, you are a teamwork with your surgeon. You must tell him that proper preoperative assessment, reference, and correction of anything preoperatively always solves problem. and they have to wait. Like patient may come for a daycare surgery, but you have to do the preoperative checkup. Patient may have developed some new symptoms that has
Very
to be
true.
corrected, or he may require some urgent reference, So cross reference, everything has to be done. Otherwise, you will end up in complications. And second is that in anesthesia, prevention is the best cure, like because the complications are all life threatening. So you have to have good preventive measures according to your protocols. Okay. And third is that I give lot of importance to documentation, which is not done properly. A good preoperative checkup, even before the patient comes, maybe as you said, some elective cases you can do days in advance when the patient comes to OPD, and then in the hospital on the day before surgery, he gets admitted. And again, in the operative hold area, because he might have developed some new like MI or anything or electrolyte imbalance. All that need to be which complicate your anesthesia has to be corrected. So documentation has to be done pre-operative, intraoperative, as well as post-operative before handing over to the intensivist. That has to be done. And what you said is that SNDT is very, very important, because most of the time when the case comes, they just sign, like we don't know who's what name and nothing. So the signature, name, date, and time has to be there, pre-operative, intraoperative chart, and post-operatively also. A very nice lecture. We really enjoyed it, really.
Thank you.
Very
Thank
much,
you.
and so much we learned. We can add now so many things, Thank you very much. And
Thank
it is
you.
a huge topic. Safety in every field, anesthesia, surgery, it's totally huge topic.
Absolutely.
But
Thank you, ma'am.
you covered it beautifully. Thanks a lot. Thank you very much.
Thanks a lot, ma'am.
Dr. Joseph, I'm going to ask you, I'm going to make a comment which I feel in my last couple of years of practice that I have found, which may not gel well with most of the people who are there in this thing, but I think I need to bring this in the forefront, which I'm sure most of my anesthesiologist colleagues also do face the same thing. Since the time the hospitals have been, I would kind of use the word into bracket, pressurized to have NABH and JACO, all these accreditation, our nursing staff have become less clinical and less patient oriented, but they really want to tick the box, which I don't see it wrong, because that's they have been asked and requested to do, and they are down the line answerable to something.
Yes.
But in this process, I see a lot of patient care being, I would say more empathy being gone, has gone away. If I were to give you just two examples, one is I had a patient for an MBR who was taken into the operation theater, and as usual, she was made to sit on the table. Her clothes were removed because the MBR is done, and leads are kept at the back, and there were males around. She's coming from a lady for her, it was very important for her to cover herself. She's being very embarrassed, but the sisters are busy taking over, and this and that, and nobody's looking into that. She's shivering. She's a thin lady, and then you go up and cover her up and talk to her, because you are also busy preparing your drugs at that time. These are the things that happen. So, and I feel that empathy is lost. They could have done that later. But then when you tell them, obviously there is a little excitement, but we have to finish this. You cannot start the surgery before that. A similar incident happened a few days ago, where the sister is very eager to finish off whether the IV line is started in the lab. Is this drip done in the lab for a patient who's been on a tracheostomy, being shifted down, and you tell the sister, relax, the surgery is going to take an hour. I will finish off this. I'll definitely give you the information that you require. But as you, I'm sure, dealing with the newer generation, they do not like to be told anything. So then there is a, like a rebuke looked on the face, which even hurts you. But you as a senior person just tend to overlook it. But how do you go around this problem? While your hospitals are busy to get accreditation so that they can get more commercial activity in, right? At the same time, I'm sure this happens more so in maybe government hospital, but so the people come to corporate because they feel that they are getting more empathy, more treatment, more personalized care. But unfortunately, this is even happening at our place. So, uh, can you give us some caveats as an anesthesiologist? What can we do? I mean, how do we deal with such things? Should we prime our nursing staff that, like this has to be done at the end, or do not do it in between the procedure? Finding out whether how many ampules were used and what all was used. I can understand for narcotic drugs, fine. We have a very fantastic rule. You do not go in without signing for the narcotic drugs. But for the other drugs, they have to be trained that this can be done for a 4-hour surgery. It does not need to be done in the first half an hour. You understand what I mean? And that's where I feel that the patient care is lost in most of the time. I really don't know whether my other colleagues agree with me.
Agree,
But
agree, absolutely agree.
yeah.
Yeah.
Ma'am, your comments on the same.
Yeah, I don't think it is a peculiar problem. It is a huge problem. All hospitals have this issue that's coming up. So it is, see, documentation is important, certainly. But what type of documentation, how much to document is also important. Now, the practice of closing non-compliances has become the issue. Now, this particular form is not there, so the nursing creates one more template. Whatever was there in the previous template is also existing. One more new form is added. Forms are getting added and added as a result of some non-compliance coming. So nowadays, we do not permit our nursing administration actually to develop their own forms and templates. Most hospitals have gone into that, into the consolidation of forms and templates, and that is where your quality team has to get involved so that there is no duplication. Doctors are taking drug allergy, nurses are taking drug allergy, even the dietitians are taking some kind of allergies. Now in the doctor's notes it says penicillin allergy, nurse's notes it says no drug allergy at all. Now which documentation do you take? If one healthcare worker is taking that, all of us have to follow that and take the decision based on that. Multiple people taking is becoming a huge problem, duplication and other issues. So the way to work around this system is to actually look at it as an exercise to sit down with the nursing team and see what are the various things the doctors are doing, and then the nurses don't have to duplicate those things. That's point number one. Number two is to also take away unnecessary documentation, because as you said, it's not just NABH. There is something known as nursing excellence. That is totally different from the NABH requirements, and there is so much to document. So whether you really want to go through that entire thing and see what are the ones that are actually needed for patient safety. If it is not needed, you have to take away all of those. So which is where your CEO, your top management, your quality team, along with the nursing and the clinical team. You leave the clinical team out of this, there is problem. So it is important to draw out that, because it has complicated the system. I'll be very open about it. And even our own doctors are complaining that the nurses are half the time documenting, they are not near the bedside at all. So that, which is why we got into this exercise of going through this overall documentation and keeping it as lean as possible, just what is needed for the patient care outcomes and the patient safety related components. But within the theatre environment, I think privacy at any given point in time, that empathy, privacy for the patient, there cannot be any compromise at all. So that is again the culture which needs to come in with all categories of staff. I, as a lady, if I'm sitting on the operating table and people are just ripping me apart, I wouldn't like it at all. So certainly that sensitiveness towards that needs to be trained very clearly, and even these are small incidents that need to be escalated. Only then there has to be a training associated with that, and you come to a solution as to when this should be done, when what needs to be done, whether it is needed at all. So you need to now start interacting as a multidisciplinary team to see how do I sort out these problems. And they may get a little upset, but they also understand. I mean, see, it's a large workforce. When you're handling about 2,000, 3,000 nurses, when the protocol is put down like that, they have to act accordingly. If they act this way, you'll end up with a problem. So there is a regimental, protocolized, bureaucratic establishment. If they cannot do away with that, because then we'll end up with problems. So therefore, we have to make sure that these protocols are looked into with the eyes of the clinicians, the anesthesiologists, the quality team and the administration. So you embark on this exercise, and I'm sure it will be good.
Thank you so much, madam. Are there any more questions from anybody? Any comments, any questions? Dr. Reshma, our patient
Good.
safety officer is here.
Yeah.
Dr.
Good
Madhuri
evening,
Nayak is
ma'am.
there. Yes.
Ma'am, good evening. I have one is I'd like to thank Dr. Lalu for giving us this enlightening thoughts. She has made our work a little more easier. One thing I just wanted to add or as a comment is that because our most of the anesthetists who are here in the group are not like they are visiting anesthetists, so they won't really know exactly what is our current work going on documentation as. But I want to appraise you all with this, that currently we are working on how to get rid of these forms and pages across the whole system, be it nurses forms, or because this is also this has come as an initiative from our top management, and we are working on this and trying to simplify these forms as much as possible. Also, we are uh, just uh, just appraising this group because most of them are visiting and they won't know exactly what is happening in the hospital. Of course, once we are little more progress on this, we are going to be informing everyone, and you will also see that most of the forms have gone away. We'll be going digital. So yeah, we are working on that. Yeah, the top management as well as this team is working on how to get rid of this excess document when the time the staff spends on filling this and ticking this, and how to increase their bedside time. So yeah, that is going on. It's a team at the end of the day. Everybody contributes in their own way, with the vision, whatever the top management or leadership would provide, and how much it's a buying. How we get buying from the leadership is also very important. So over a period of time, I think I'm sure we'll all evolve, and there will be yeah, it's a continuous journey. Quality is a continuous journey. So yeah, and we have already begun. So thank you on behalf of our team, and for in making us also participate in this webinar, ma'am. Yeah, over to you, Dr. Kalpana.
Madam Prajakta, would you like to make some comments, please?
Hi, good evening all, and hi Lalu. We
Thank
have
you,
been
ma'am.
meeting on other forums too. And thank you, Dr. Kalpana, for inviting. There are many nurses are there in this webinar. And I must say that your presentation was very simplified. And as you said, initially when accreditation came, because I have also had 2 cycles of JCI, and I see the difference. They are more of process oriented, or they see from patient journey point of view. And we are not far to have now compulsory or mandatory, at least those who are accredited institutions, to have a patient advisory council. So I feel the patient engagement will definitely bring lot of good things to our healthcare, and it's a journey, as everybody believes. And initially, if I may say, anything to do with accreditation, it was always that it is nursing who is going to do it. This is a hard truth. If you say, and that's why they also feel sometimes they cannot say no, because it's not in all hospital that they have empowerment. But yes, lot of work is, if may I say, push when it comes to accreditation. So I think team effort and consolidating the information and making use of technology will help. As simple as allergy, if you have a technology tool, it can be entered in one go. So even patients are also not hassled that same question of allergies asked to them. And it can also include food allergies. So simply, if you can think about, all those safety related information, how we can make use of technology. And I'm sure nurses being the largest workforce, they need lot of collaborative support from their team. And I'm sure, this particular accreditation with humongous paperwork, that particular, way of looking at it will slowly disappear. So thank you once again for a wonderful session, and I must appreciate Kalpana and my whole team who has joined on a Sunday afternoon.
Thank you.
Thank you.
Pratika. Yeah, and all of us appreciate the efforts taken. And it's a teamwork, it's a huge effort. As she rightly said, anything new, it is the nurses who actually come forward and take it up. And in the process, there are too many things that are added on to them. I strongly believe, as she rightly said, technology is the way forward. Several duplications can be avoided by using technology that is available. It can at one go be available for all the multiple stakeholders in the hospital. Thanks, Prajakta.
I have one suggestion. When the patient books, I mean, in particularly pediatric cases, when they are booked by the parents, they pay advance and all that. That time only patients, all the information should be, put in the digital form. So you come to know even before that.
Yeah.
Because routine cases, they are booked at least a week before or whatever, 2 weeks before, whatever the time they are booked. At that time only, if the patients, all the details are, clinical details, whatever the history and all that is put in the digital form. As soon as we get the patient's name, we can get all the information.
Absolutely. Many hospitals have gone ahead with that. In fact, in my own setting, it is available. Not at the admission level, but clinicians at various levels get consolidated and made available for all the other clinical leads. It's a very good suggestion, ma'am.
I see no more questions. So I think we are all satiated with whatever we have learned today. And thank you so much, Dr. Joseph, for this Sunday afternoon. Very enlightening talk. And you have surely impressed our young minds as well as most of our nursing staff. And of course, my fellow anesthesiologists. You put us on a different kind of a bubble for us to go ahead with patient care, quality care, and safety, especially as anesthesiologists. I thank you once again for this very enlightening talk, for spending the Sunday with us, and I look forward for meeting you for some more forums like this. And I hope to have you once again here for some more talks again. Thank you so much, Dr. Joseph.
Thank you, ma'am, and thanks for the invitation. Thanks everybody for your patient listening, and have a great evening and a week ahead. Thank you.
Thank you, everybody, for joining us. I appreciate all of you joining us on Sunday. Thank you so much.
Thank you, Kalpana.
Thank you, Kalpana.
Thank you. Thank you.